So now we've talked about frontline therapy, and so now we're quite lucky to have many options. So what is your preferred second-line treatment, like after a patient progressed on the frontline therapy?
I think, following an IO doublet, well, first of all, I should say we have no data for anything in second line.
So what you want.
So, we can all argue that we have the best plan, but none of us have any real data. After IO, my preferred sort of second line option is a TKI. These patients are VEGF naive, and so, for me, it makes a lot of sense to use a TKI in that setting. After atezo-bev, again, we don't have good data. I think TKIs are generally, a reasonable choice, and exactly which TKI, I think it's really dealer's choice. I do think there's also data for ipi-nivo post atezo-bev. There's a response rate of about 20% retrospectively. And so that may be an option in some subsequent line, maybe second or third line, second line if they bleed on atezo-bev.
Yeah, I think what you've said is quite reasonable. The de facto treatment sort of has been this TKI for many people in the absence of randomized data. Obviously, there are some ongoing studies that are looking at second line, TKI versus TKI plus atezolizumab, the idea of continuing it, whether that study is positive or negative, at least having the comparator arm of the TKI will give us some operating characteristics of that in this population. That's really not happening in the United States, but in Europe. And so that will, I think, be informative. Of course, as a result of the progress in the field now, a number of novel therapies are being assessed in the first, second line plus, so I think there will be movement in the years to come in that space.
I have a question. Is the idea that if you have availability of TKI and the fact you are giving it in second line is better, would that be a reason that you preferentially do dual IO in the front line so that you have a second line option available for your patients? Is that a good enough reason to do that?
Not for me. I mean, I think we have a second line option regardless of what they get first line.
But didn't you the idea that if you got atezo-bev in the front line, they've had a TKI, you still do a TKI, versus if they got dual IO, then lenvatinib becomes an easy second line choice. Does that make any difference? I always wonder.
We need a larger study to really, prospective study to show that.
Well, maybe we need real world data to see what was the PFS2 on these two studies.
No, it's a good point.
Mm-hmm.
So we've talked about the management of AEs, and usually we collaborate with hepatologists within the MDT team. We're all quite lucky to have a big MDT team to work with us. So what is your experience? How do you work with your other specialty in the team in terms of managing this disease?
So I think I think it's a continuum based on the stage of the disease the patient has, certainly. For me, a patient who's presenting with early stage, stage A, this is a real DMT discussion to assess how surgery, transplant, local regional therapy might be applied in that setting, with or without systemic treatments on trial. But the idea really is to bring all patients to a competent disease management team that can help drive to cure with those modalities. I'd say for the intermediate stage, we're really interfacing with IR, hepatology, quite frequently to understand the best local regional approach and how to manage there. I'd also say in the later stage, particularly with immunotherapies, I find that we need to engage a number of medicine subspecialties, particularly for the immune-related adverse events. I don't know what you do with regard to that.
Like absolutely right. If it's hypothyroidism, I can manage, but anything more than that, I definitely ask a lot of different folks to come in and help as a GI to manage, their immune-related colitis. Usually endocrinopathies are the most difficult, in my opinion, to manage once they develop Cushing's, or if they develop, adrenal insufficiency. Those are hard, and you really need endocrinology on board. And then the hardest part is distinguishing mild like autoimmune hepatitis versus disease progression versus is it their underlying cirrhosis progressing, which is always, it's such a multidisciplinary discussion, but it's very, like in clinical practice, when I'm seeing patients, that's one thing that is very hard to distinguish and treat.
Anything to add?
No, I agree completely.
Yeah. So we are here at the ASCO meeting. There are a lot of excitement. So across different cancer type. And so if we want to look into the future a little bit, what are you excited about the new drug development in HCC? Mark, you can start with.
Yeah, it's a good question. I mean, I think there's probably more room to run with checkpoint inhibitors. I mean, we know that CTLA-4 adds to PD-1. We know that VEGF seems to add to PD-1. I think in the very near term, we have triplets that are at least in development, and the first to read out will be the Skyscraper trial, which is a TIGIT added to atezo-bev. It looked like a very positive phase 2, but TIGIT has had challenges in many tumor types, so it's not a foregone conclusion either way, I think. We'll just have to see what the data shows. Earlier on, we have a lot of interesting therapies. GPC3 is widely expressed in many HCCs, and we have, CAR T-cell approaches coming for GPC3, radioligands coming for GPC3, antibody-drug conjugates coming for GPC3. So, exactly which approach will win, I don't know, but I imagine we'll have something. That's at least some of what I'm excited about.
I 100% agree with that. I think we'll also be seeing, as you noted, the bispecific space. There are a number of potential pairings there that have shown some preclinical significance and are actively in clinical development. I also think that there's probably room to understand better local regional approaches and these types of systemic therapies. For example, TACE has now been very well studied with immunotherapies, although in the United States we often use TARE or radioembolization. Will that change significantly? What's the safety? What's the status of that? I think that will be interesting.
I think at all these things that you just mentioned, I don't think vaccine. You have your vaccine study. I was reading through it. I didn't know Mark was your study, but fibrolamellar variant of HCC is relatively treatment resistant and not much options. So I'm very excited about that you're actually targeting a very unmet need area.